Good morning. Is the microphone? Are they hearing me? So when they hear me vibing earlier?
No.
They didn't hear me vibe. Good morning, my internet friends. Welcome to the Medicare Cafe. We're in the pre-chat section. I'm caffeinated. I literally was dragging my sleepy butt into the studio, and then the camera went on, and I just went, snap, I'm in her. Guys, I have some updates for you. This has nothing to do with Medicare. I didn't know this. I just found out a really important piece of information that all my friends need to know. Chaylin just informed me that Apple, the company Apple, Mr. Jobs himself.
Well, the company.
Nope, Mr. Jobs.
Sure.
My good friend Steve from the grave bought the rights to Peanuts, like Charlie Brown.
Charlie Brown, yeah. Like 2 or 3 years ago.
This isn't new?
No,
I
this is
thought
not
this was
even
new
remotely
news.
new.
This is not
This
new
is like
news.
yeah.
Why didn't nobody tell me
There
this?
was like a whole Christmas season where we like didn't get Charlie Brown Christmas or any of that stuff because it was only on Apple TV.
I didn't know this.
Yeah.
I didn't
and then
know
they
this. I
finally
didn't pay
came
attention.
to some deal after backlash and,
because they took
people's
Charlie
childhoods
Brown.
being stolen from
They
them.
just leave it to Apple to steal people's childhoods. So Apple a few years ago. So there's two things that truly have like rocked my childhood when it comes to like corporations, I think is what they're called, plural. This is one of them.
Yeah.
I'm unwell with this news. I am not that I'm not happy. I mean, like, Apple, go live your life, queen. Whatever.
Sure.
I'm not happy. And then number two, when Winnie the Pooh, what is it, not trademark? Or what is it whenever, like, they lost.
Public domain.
They became, like, a public
copyright
thing.
expired.
Yeah, and it was basically, like, they've been around long enough that no one could, like, own them anymore, or some sort of insert legal jargon about ownership of ideas here.
Copyright expired after 95 years in the U.S.
I didn't know that. And so that happened, and then immediately afterwards, the internet is a terrible, scary place.
Yes, it is.
And immediately after that, people started making some like horror film that Christopher Robin came back to the woods and the woodland creatures murdered him very graphically. So anyways, my childhood is bruised. That's it. Welcome to the Medicare Cafe. Today you were joined, it is at the top of the hour, so we can get started. Unless you guys have some more follow-up questions on Charlie Brown dancing to an iPod and
Olivia's childhood.
my childhood in general, and Charlie Brown and meets Winnie the Pooh, what do they have in common? Corporate. You're joined today by your host. My name's Olivia Richardson.
And I'm Jalen Jackson.
And we got a really fun episode planned for you today. And by that, I mean the episode is in your hands. We are doing an Ask Us Anything episode. I've been out of the studio quite a bit the last few weeks. So if Chaylin, we have been on the move, on the run. We've been training. We've been meeting. We've been in Dallas. We've been in Arizona. We've been in New Mexico. We've been everywhere trying to basically make sure that agents are aware of what to do and what's coming up this AEP. Been a part of some really wonderful meetings, some really great conferences, and getting a ton of questions. And so we just want to make sure, like, as we're approaching really the final leg of AEP prep.
Oh my gosh, yeah.
I mean, we have 28 days left before things get just like there's no turning back. Before, like, if you don't accomplish what you want to accomplish in the next 28 days, then your quarter 4 is shot, right?
Yeah, absolutely. 4 weeks, 20 working days.
That's nuts. So so this is an Ask Us Anything. You can ask us questions about literally anything. So you have two ways to ask us questions. Number one, joining the messaging us on our live chat feature. I don't know what side. Down. Messaging us on live chat. Ring that bell. And doing it that way. Or, of course, you can text me. My text phone number, that is my real phone number, so you can text me at any time, day or night. Probably not night, because I am very sleepy. I didn't tell the world this. My son just got RSV over the weekend, so, like, I am running on no sleep. But I appreciate just your patience and love and care. If you can text me, of course, my number is there in the chat, 573-818-2688. Feel free to text me. That is my real phone number. Or, of course, message us in the chat. I've said that 5 times now. Just talk to me. Ask me a question. It can be about AEP. It can be about Medicare. It can be about legislative changes. It can be about what we had for breakfast. It can be about anything you want, but don't make it weird, okay? Please. Okay, so as we're doing that, Shaylin, I'm
Yes.
putting you on the spot here. As people are going to start sending in their questions, we did get some questions ahead of time, but just to give some people time to actually start asking those questions, I would like to hear from you. Again, I know we kind of talked about like if things go stale, which I know they won't. But if things go stale, what are some things we can use to fill the space? With just like an update from you, I know you're super involved in what's going on in NAFA. I know NAFA, NABIP. You're very involved in all of these different groups and organizations. What's something I'm asking you? No one asked us this,
Yeah.
but what's something right now that like is a top priority for these groups that I call agent advocacy groups that people are joining? What are some things right now that are on the docket when they're meeting with legislation, when they're doing this? What is our industry saying is most important to us right now as agents?
Yeah, so I think across the board, if you look at all the trade associations, whether it's NABIP, NAFA, HAFA, several of the others, the number one thing on everyone's mind is how do we change the dialogue around what an agent's role in the marketplace is. Definitely a lot of confusion and concern about how agents are portrayed, whether it's some research studies that have come out or all these public hearings that we have in the Senate or in the House. What is the role of the agent and broker, and what does that mean for beneficiaries and for at the program level for the Medicare program? So that's definitely top of everyone's mind is how do we change that dialogue? How do we paint a better picture of not only what agents are required to do, but all the things they're not required to do that they do anyway. So, all of that, kind of care after the sale, whether it's helping with claims or prior authorizations or finding a new pharmacy, finding providers, working through ancillary benefits, advising folks throughout the year on how to access their care through their plan. All of those things are really kind of minimized in the dialogue about what agents and brokers do. So how do we change that? NABIP, of course, has famously done these beneficiary surveys where they've collected somewhere around 15,000 surveys from Medicare beneficiaries about what their agent means to them and why they work with an agent rather than calling an 800 number or going online. So really trying to utilize all of that data, try to pull out commonality talking points that we can use when we're on the Hill or talking to a legislator or talking to a policy group or a think tank. And those can be really, really great to use when we're trying to drive that conversation of what does it mean to be an agent and broker and why do they deserve a place in the market.
I love that. And again, that's kind of where, again, it wasn't just a couple years ago where all those conversations started. It's been something, again, whenever the addition of the call centers entering the space at the rate that they did, but it brought a lot of attention to what does an agent do. Now, we've seen a lot of proof in other industries. We're talking like the ACA, like how moving away from navigators, moving more towards the agent. So we have a lot of things on our side for that. And again, if you are interested in being a voice in that, joining an organization like NABIP, like NAFA, like HAFA. What's HAFA stand for?
Health Agents for America.
HAFA. That's a good one. You gotta look like ha. So that would be awesome. Again, getting involved in that. Let us know if you have questions on how to do that. We do have some questions that are coming in, so wanting to make sure some of those are getting addressed. So one of them is one that we've heard a lot on. We've talked about this a lot. So if you thank you for asking these questions. I also am getting a lot of good morning. So good morning, everybody. One question is, with looking at prescription drug plans, losing commissions, and most of them not bringing them back, should I continue to write PDPs? I have thoughts on this. We recorded an episode with Bill Curray a few weeks ago, and we played a game of Yuck or Yum. That'll be released here soon, actually next Tuesday. That episode is being released, so we'll talk about that. But him and I were under the very same opinion. But we've talked to insurance agents, actual people in the field who are having to accommodate the influx of consumers are going to have this year, and they think differently. My gut, my everything is saying write the PDP. Write the PDP. But do not take up valuable space in your calendar to write that PDP for a lot of different reasons. And the only way that you can do both is leaning into your technology. But yeah, I do. I mean, what are your initial thoughts on the PDP?
Yeah, I think a lot of it depends on how you plan to manage that relationship with your clients and how comfortable you are saying no to people. Because here's what I would tell an agent. If you expect to get questions and you plan to answer those questions throughout the year on that drug plan, you better be writing it so you're agent of record.
Yeah.
If you're planning to answer your clients' questions and continue to service them, spend the extra 5 minutes to take the app, be agent of record, even if you're not commissioned, and then, be able to actually service that client. Because if you're just helping them out and saying, go enroll in Medicare.gov, here's the plan we think you should pick, you're going through everything except that last step, and then you're getting almost no access to the information, won't be able to call the carriers and help. You'll lose everything that makes you valuable as an agent, and give it, but you've still done the work. So do the extra 5 minutes of work and complete the enrollment.
I don't mean to come across as like calling people out, because I'm not, because I understand, like, at the end of the day, you have to make money doing this. If you don't make money, then you can't keep your doors open. You can't keep doing this. You can't keep helping seniors. So our goal is to make sure that agents stay profitable. Writing non-commissionable plans is really counterintuitive to that commissionable. But if we look at it from the dollars and cents, right? One, without looking at it from the dollars and cents, it's the right thing to do. This is the coverage that your clients are most likely to use on a month-to-month basis, is the one that they're going to be most interactive with their finances compared to their core product like a Medicare supplement or Advantage. Of course, this case, like a Medicare supplement, final expense. This is the plan they're actively most likely going to be using. So to not be a part of that and to not support in that, it doesn't sit right with me when you're saying that you're advising people on financing their health care. That's one of the biggest parts of financing their health care is their prescriptions. So that's one. But even looking at it like dollars and cents, as a business owner, as somebody that's saying, what am I getting paid for my time? Because I can't afford to get paid zero for my time. You can no longer view prescription drug plans as an income source, even for the commissionable ones. And a lot of people would have argued that prior, because the commissions were never substantial. There were never commissions. It takes a lot of writing PDP plans for that commission to be something to live off of, right?
Absolutely.
Now, lumped together, obviously, it's pretty substantial whenever some carriers went non-renewable or like they didn't renew those commissions. That was obviously very impactful to people's livelihoods and income, but that was years of building up that book of business. People weren't making a living off of writing prescription drug plans. However, there is an incredible source for referrals. It is an incredible source of retention. It is an incredible source of lead gen in a lot of cases. So dollars and cents wise, you're not looking at it as an income, but it absolutely is generating revenue or saving you from losing some of that revenue. So if you look at it that way, it does make sense dollars and cents, and it also makes sense as far as a value add.
Yep. Well, and it's just one of those things where, again, I'm a big believer that every agent has to make their own business decisions. If you don't want to mess with PDPs, truly don't mess with them. Don't go halfway with it and help someone find a plan, but then tell them to enroll in Medicare.gov. Either tell folks, sorry, we don't do that anymore, or go whole hog and do the work.
I think that's a great thing. Do it or don't. Will asked a wonderful question and a really relevant question, knowing now that all the sneak peeks are out. We're seeing the benefits. We've listened to Def Research talk about what's going to happen this AEP as far as what plans are going to look like. How would you approach the conversation if the extra benefits on a Medicare Advantage plan gets reduced, but the primary health benefits remain strong, and a client is asking to switch for those extra benefits? That's a really great question. And again, really relevant. We're going to see a lot of these plans who are having to accommodate less money that they're receiving, higher risk adjustments, everything. Like, carriers are financially going to continue to see a ton of pressure. A lot of them are making the adjustments in those extra benefits. Some of them, like, in the real benefits too. Like, I mean, you're going to see more co-pays versus co-insurances on medications. You're going to see increase on co-pays of specialists in a lot of these plans. Not all of them. Some of them look really great.
Higher max out-of-pockets.
All of
higher
that.
Hospital inpatient co-pays.
So an individual, so paint this picture. You're sitting down across from a client. A person says, I really, like, I don't use my dental. Let's just say dental. Dental is one that's getting attacked hard. My dental benefit is going from I'm getting all this covered to now I'm getting nothing covered. I don't want to be on this plan anymore. Yes, my doctors are still in network. Yeah, it probably is going to cost me less, but like, I would rather go to a plan that's going to support my dental. How do you respond to that? I'll ask you first, since I kind of answered the question first
Did you
last time.
use the dental this past year?
And science says no. People don't actually use the benefits, but they want them. Yeah. Okay, so did you use the benefits? No, but I really but I am wanting to make sure that they're there.
Great. We have a solution for that. We can sell you a standalone dental plan that will not change year over year, unlike your MA plan. We can lock you into a plan right now today that you never have to worry about changing or going away, and then we're free to move your medical benefits as needed.
I love that. I think that was exactly where my head was going. It's like, if dental is that important to you that you're willing to sacrifice for it, then let's just do
Spend the
both.
money.
Let's spend a little bit of dollars, get you a little bit of dollars, not a lot, and get you an actual dental plan, because that seems to be really important to you.
Yeah.
And I think highlighting that, yes, it's here this year, but it's likely going to change next year. So and I think it's educating your clients about the risks.
Yep.
And if they choose to go there, you've educated them about the risks and they're okay with that and they want to make that plan change anyways, then make the plan change. I think, because if they're going to make that decision, they're going to do it somewhere. You don't want them to not do it with you. Just maybe that's a hot take, but if they're understanding okay, I can change you to get you on a dental plan. One, this is likely going to look very different next year. So this is a 1-year plan. We're going to have to do this again. Two, this plan, if you actually need to use the health benefits, is not going to work as well as this other plan will. So do you understand that you're making this decision based off this when that's not how the plan's designed to work? And if you can kind of educate them at how that looks,
Absolutely.
and they still want to switch, then make the switch. Then go ahead and switch that and be ready for OEP to revisit
Switch
them
them
and be
back.
are you sure you want to stay on this
Yep.
plan? Keep note of that for sure. Great question. Okay.
I would agree.
Another question we have. Oh, this was one I actually saw. It's actually come in a couple times. Prior authorization. We're hearing a ton right now about prior. Every sit down conversation I'm in, prior auth is being brought up. So this one is asking. So prior auth is going away, but also coming back for original Medicare. Can you explain that? That's very understandably confusing that we're talking about Medicare Advantage plans are now going away with a lot of prior authorizations. Jalen, do you mind kind of talking about what we're talking about, and when they're saying it's coming back to original Medicare, maybe shine some light on yes, but only kind of, and in some states.
Yeah, so obviously we've seen a huge push over the past several years to reduce, streamline, make more efficient the prior authorization process, especially with Medicare Advantage. That's been a huge talking point, whether you read the articles about things like gold carding or just making it an automated system by 2026. There's been a huge push in Congress for this. There's been a huge push with the current administration for this, so much so that they did get, rather than doing it through regulation, they got voluntary commitments from most of the major carriers to drastically streamline and reduce prior authorization going into this next year. So that's going to be a good thing for MA folks. This is also a part of the reason, not the only, but a big part of the reason that we're seeing a big shift away from PPOs and towards HMOs.
That makes a ton of sense. More managed to manage the expenses that's coming with.
Well, and it's very hard to create a gold carding program when you have a PPO and you don't actually know which doctors you may be paying for services, because any doctor can just say, yeah, we will accept those payment rates and we'll accept your PPO. So when you don't know which doctors you're going to be paying out, it's really hard to create a gold carding program or reduce that prior authorization burden, because you don't even know what doctors your patients are going to go see. So an HMO, something with a little more tight network, a little more managed care, you can create incentives within those networks to incentivize high quality prior authorizations. You can better track those prior authorizations and create a gold carding program. It's going to make a lot more sense in the long run when it comes to reducing that burden of prior authorizations on the providers and on the clients.
So what does that look like from a client perspective then? What will be different in 2026 when a client goes to receive a procedure or goes to receive some sort of testing that needs to be done? Will the client notice a difference in 26?
Yeah, in a perfect world, the difference the clients would notice is they don't even really know if a prior authorization is happening.
Okay.
in a perfect world, like it's just something the doctor does on the back end. It goes through smoothly and seamlessly within a matter of
I love this
hours, not
perfect world you live
days.
in.
Well, you know, and the client, the consumer, never really even knows what's going on.
Okay.
So the goal is to create faster systems, electronic health record systems, or like an API feed between providers and carriers that allows them to submit those prior authorizations more efficiently, get responses more efficiently. And there's been a big focus, you know, obviously AI has been huge in the news. There's been a lot of talk about how do we use AI in things like care determinations and claims processing, and a lot of the discussion.
Kind of scary, like
Oh,
human error.
for sure.
Human
for
error
sure.
gets taken out of it, but then you're also like, I mean, like on the drama side, go Terminator, or AI is determining if you live or die. Like,
Yeah,
like
well-
that's obviously not 100% accurate, but like
Sure.
that's where.
That's
people are gonna-
that's the news
that's where my
articles
head
you'll
went.
read. That's what's going to be in the news.
Yeah.
It's not like no one's going to give AI credit for saving thousands of lives. They're going to, you know,
Terminator.
demonize it for
Terminator
ending
rules.
a few, and that's the way it happens sometimes. But I think, you know, that's one of the big pushes that we've seen from Congress, even though they haven't undergone, you know, legitimate rulemaking around AI use in healthcare yet. The big push has been for only allowing AI to be involved in affirmative decisions. So AI can be used to approve prior authorizations, but it still takes a real person to deny it.
Okay.
So that's one of the big pushes we've seen.
Got it. Here is a question. We're getting a few questions coming in, but I do want to make sure we're respectful of time. One question is, will we continue with the benefits and everything going crazy for this AEP, kind of what we talked about, the financial pressures? Are we still expecting to see a large amount of people switching from Med Sups to Medicare Advantage plans? And that's interesting. I think my question to that would be, what do you consider to be a large amount? Because as we saw, I think we need to shed some light on, like, we're seeing, maybe clear up of, like, break some rumors. Like, rumor has it, you know, that people are leaving Medicare supplements in droves and trying to get into Medicare Advantage plans. And if you just look at the stats blindly, it's understandable why you would think that, because Medicare Advantage plans right now are like 57% of the market. If maybe
Yeah, it's
not,
astronomical.
and they're saying by 2030 that's likely to be between 60 and 67% of the market share will be Medicare Advantage plans. But what's interesting and what we're seeing in that, it's not so much that Medicare supplements are losing market share. It's just that you're going to continue to see less people on group insurance, less people on standard, just standalone VA, less people doing alternative things versus a MedSup versus Medicare Advantage plan. So what we found last year, again, Deft Research, who is an incredible partner of Integrity, does a gut check every single year. They do about midway through, they do a few thousand seniors and basically ask them about their intentions come AEP, what are they thinking about the market, how do they feel about their plans, their loyalty. It's really, really cool stuff. There's a webinar Integrity is going to be putting on coming up in the next couple weeks to discuss that. It's going to be pretty cool. But what they found was last year, it was actually one of the top years that people left Medicare Advantage to go back to original Medicare and get on a Medicare supplement. And of course, those numbers might be a little bit skewed because people at that point up to then had been kind of leaving in larger numbers. So you probably saw a lot of buyer's remorse. The first AEP that they were on was crazy, so they went back to that Med Sup. So we did see that. But we're also seeing people with the rising costs of Medicare supplements, I think, okay, so it was, if your Medicare supplement goes up $50 a month, less than 40% of people considered moving to a Medicare Advantage plans. If their premiums went up $50 per month, it was less than 50%. It was around 40% of people said that they would still not switch to a Medicare Advantage. They were going to look and shop for a new Med Sup, but they were not going to leave that Medicare supplement to go to a Medicare Advantage plan. So all that to be said, we aren't seeing a mass exit of Med Sups, even continually, and the research is showing that we won't see a mass migration of Medicare supplement clients to Medicare Advantage clients, even with the large Medicare supplement premium increases that we have been seeing and will continue to see for the next few years.
It's almost like people buy med subs for a reason.
Truly. I think that's like such a great point. It's bringing out what is this market doing for our industry, this upset, tumultuous market, which I've been really practicing my tumultuous. No one's been talking about that. I've gotten really good at saying tumultuous. That was a word I could not say earlier. Anyways, I think this is really, it's going to, I think the theme of what I'm hearing, both on the carrier side and on the broker side, those who will survive will thrive.
Yeah, absolutely.
And by that, I think we are getting back into a role where agents have to be actual advisors and not order takers, or not like, what's the cheapest?
Yeah.
What has the best dental? What's the best? What's the worst? Then I'm going to shove all my clients into this thing. No, it's going to be, you actually have to educate people on your options and advise them and help guide them into what financing their healthcare is going to look like. And I think agents who are not into this for the right reasons, or agents who are not investing in their own education, they're not going to last. They can't cut this style of sales.
No, I agree. Well, and I think this past AEP showed us a lot how critical communication with your clients is. Because, yes, we saw a huge number of folks go from MA back to Med Sup. A lot of that was because we had 1.8 million people on non-special needs plans that had service area reductions. So that was a huge chunk of people that all of a sudden had a guaranteed issue opportunity to go back to a Med Sup. But what was even more shocking was that if you look at the numbers of folks who have original Medicare only, they don't have group insurance, they don't have a Med Sup, they don't have MA, just original Medicare, A and B. That number typically creeps up a tiny bit every year, but between 24 and 25, it jumped up 500,000 people. And that doesn't tell me that all of a sudden folks think original Medicare is a great deal. It tells me that a lot of folks had service area reductions and woke up on January 1st without a plan.
Yeah. That's crazy. And that's why, like, for this AEP coming up, we're talking about, like, yes, this is round 2. I mean, I think it was been talked about how, like, aftershock, like last year was the earthquake. We're now going through aftershocks. I'm now hearing that's not true. We're having another earthquake this year as far as market disruption. And they're saying, one, continual planned pressure, financial pressure, company financial pressure. But two, we will have more engaged consumers than ever before, because there's a tremendous amount of people who, I think they said it was like 90+% of people received negative information on their ANOC. But the amount of people who actually looked at their ANOC and like researched and actually shopped last year, though the shopping rates were the highest they've ever been, a huge percentage of people still had no idea what was happening until they went to use their plan January 1st and couldn't. So this year, people pay attention. This year, people are very engaged. And so we're going to continue to see, I think, again, Deaf Research, their gut check. Go to this webinar. It's going to be in the middle of September. Please go to it. It's incredible information that they're putting out. But one thing that they mentioned was that they do an estimation of, like, the shopping rates versus like buying rates. Shopping rates are expected to be at another all-time high as far as people actually shopping, but they actually looked at switching. So the difference between shopping and switching is shopping is look at what benefits I have an appointment. Switching is enrolling in a new plan. Last year, even with the market disruption that we had, the switching rates were estimated to be at 17%, even with shopping rates over 70%. The switching rate was estimated to be at 17%. It ended up being at 16%. If you look at Deaf Research estimation versus what actually happens, they're 1% off, and they have been since 2012. I mean, they get it dang near every single time. This year, they're estimating that the actual switching rate is going to be at 21%. So even higher than last year's. So we can expect to see around a 20%. You know, they're estimating 21%.
7 million people.
It's going to be crazy. So this AEP is going to be one for the books. Be prepared. We can talk about this all day long. And I know we need to be wrapping up this, but Chaylin, if you had 3 tips for a successful AEP, knowing that we have 28 days left of prep, outside of get your stuff ready to go, so October 1st you're having appointments, and yes, I said October 1st. Chaylin, what's your top 3 tips for having a successful AEP?
Learn how to reassure people quickly and in bulk. there's going to be a lot of people
That's a good one.
that need to change plans, but there's going to be a lot of people that just need their hand held and to be told everything's going to be okay.
Mm-hmm.
Because even people who are seeing benefits degraded on their plan, that doesn't mean there's going to be a better option for them in the market. So people are going to have to get used to the idea that there may not be a better plan out there, and they're just facing some cuts this year. So figuring out how to hold those folks' hands, how to get them through that process quickly and efficiently. Maybe that's ANOC meetings, maybe that's group sales events, maybe that's some other kind of community meeting where you can talk to a lot of folks at once. That's going to be key. So efficiency and figuring out how to take care of those clients that don't need to make a change but still need to be reassured. That's going to be number one. Two is going to be, how do you capitalize on this opportunity? Make sure you've got time to see new clients. If all you're doing is chasing your tail trying to save your book of business, you're losing money. You're flat out losing money. So how do we find time for new clients, and how do we get those new clients to find us? Whether that, you brought it up earlier, those PDP folks, they can be great referral sources, great lead sources, all of that. Listen, if you're doing it, great. If you're not doing it, great. But understand that if you're not dealing with drug plans this AEP, those are your, opposition in your town. That's their best prospects. They're anyone willing to do something you're not. That's going to be the challenge.
Yeah,
So really looking for opportunities like that. Look for free media opportunities. With all of the tumult this year in the market, there is going to be a huge opportunity to get in front of your local TV station, local radio station, local church groups and civic organizations, local newspaper for an op-ed or some kind of free or earned media where you don't have to spend the advertising dollars. You are the local expert. Present yourself that way. Try to get on that local show or local media source to talk about what's going on and why it's so crazy this year.
Great point. Do have a couple last minute questions that see if we can get through it really quickly. Are Medicare Advantage hybrid plans dead? Aetna discontinued my hybrid platinum plan for 26 in my area, and I saw no other carriers in New Jersey. So by the hybrid plans, there's a couple. I guess Mike, you might know better than me. What do you mean by a hybrid plan? Do you mean the plans that are Medicare Advantage plans but act like a Medicare supplement, higher premiums, PPO style, brighter networks? Or hybrid, are you meaning the partial D-SNP plans? Because I've heard those referred to as hybrid before. Quick answer to that would be, and again, if you know anything happening as far as like how the plans are being developed, super helpful there. But I know some plans are eliminating the types of plans that are costing too much money for them to maintain and not seeing the right amount of membership of people coming into those. So just keeping that in mind. But as far as,
I think that's a really good point because you said something really important, the right amount of membership. And this is not just speaking to those hybrid plans, but I think what we learned last year, what a lot of folks knew, but what I hope everyone learned last year is that there is a world where a plan can take on too many members.
Yeah.
The right amount of membership doesn't always mean a plan is too small to be sustainable. It can also mean that it's too big to be sustainable.
Yeah.
And really looking at the signaling from carriers, if they pull something off an enrollment platform, if they decommission a plan, they are telling you that plan is not sustainable. And if you're looking at your business from a business owner perspective, putting clients in a non-sustainable plan is generating more future work than you need to take on for absolutely no more commission than you're earning today.
So this is something, it is a great question. They did clarify that they are talking about plans, Medicare Advantage plans that look like Medicare supplements. So I am noticing this, that it's not just Aetna that has pulled those. We've also seen some of the regional carriers, like in Illinois, the Blue Cross plans pulling theirs. Well, are they? Maybe I'm saying something out of turn. Did I make that up?
I would have to look.
Okay. Don't take that to heart. Maybe I made that up. But I am seeing a lot of these plans. Carriers are launching, as far as a lot of them, not all of them, not UHC, but carriers like Humana, Aetna, some of the other big ones are saying we want to offer several different types of plans because we want to be a suitable option for all different types of people. That's what a strategy is for a lot of these carriers. But it is a really great point. I hadn't noticed until just now, but a lot of them are pulling back from that look-alike plan, from that hybrid plan. And that's an interesting thing. That's something to keep an eye on. I don't know that I really paid attention to that before.
Yeah, well, I mean, if you look at what's happening in the med sup market and you've got, 30 to 40% rate increases on med subs becoming more and more common, why on earth would an MA plan that looks like that be appealing to a carrier?
That's kind of what I'm thinking, because I imagine people who want that plan are people who are okay paying somewhat of a premium, not a MedSup premium, but are going to utilize their plan more than others. So that's a great point. Another question we have, are carriers keeping the COVID shots as covered option, or under the new CDC guidelines, are those with certain health issues? So are we expecting to see changes in the COVID vaccines?
Carriers really don't have a choice in this. They are required to cover all vaccines as recommended by ACIP at $0 cost sharing. So if a Medicare beneficiary is still in a position where they are recommended to have the COVID shot under ACIP guidelines, it will still be a $0 copay for that shot.
But do we know that they have to be recommended? Do we know that it has to be recommended, or is it anybody who wants the vaccine?
No, it won't be anyone who wants it. It'll still be under the ACIP guidelines, which have changed recently.
Okay.
Yeah.
Perfect. Let's see. Blue Cross pulled their MAPD lookalike supplement known. That's what I thought last year. I thought so, Mary. But as I said it, I was like, ooh, I'm saying this live and I don't have my fact checker on. So thank you, Mary. Yeah. So we are seeing companies kind of Medicare Advantage plans kind of pulling away from those lookalike plans.
Nancy brings up a great point. Sometimes folks may want to look at one of those lookalike plans because they can't health qualify for a MedSup.
For sure.
Very valid point. But again, just something that's really difficult for a carrier to make profitable, because if that's the type of clientele they're drawing to that plan, understandably it's something that, just like MedSups, it's likely going to struggle with loss ratios, and also way more restrictive on what that carrier on the MA side can do in terms of increasing premiums, changing benefits. You know, they're up against the TBC threshold every year during bid season, and it's not going to accommodate that 30-40% increase that we're seeing on MedSups commonly right now.
Yeah. Great question. Thank you, somebody who asked that, because I don't think we've addressed that outright. So wonderful question. Guys, it is 4 minutes past 10:30. Just a couple updates for you guys. We will continue. Next week's episode we are going to be posting a recorded episode. Like I said, our office is playing Trained Planes and Automobiles, trying to make sure that we can make it to all of these events, all these trainings that we're doing. So we are posting. It's going to be a really fun episode. It's actually me and Bill Correa. He's our vice president of partner engagement at Integrity. He sits down right there, and we play a game of Yuck or Yum, and it's really fun. So so make sure you stay tuned for that. That'll be next Tuesday. And then also, I'd love to hear from you guys. Let us know. Shoot me a text. Like we've done for the last 9 years, we'll continue to do Medicare Cafes throughout AEP. Probably we'll do a couple segments. We'll be doing some updates. What are we hearing from the agents? Like question of the week. Yeah. We'll probably do some more, but they'll be shorter episodes, talking 15-minute episodes. Question of the week, update of the week, things like that. But if you guys have any ideas of fun games or things just because to give you guys a little coffee break in your day to come back and watch, we want to keep you educated. We want to keep you entertained. So let us know if you have any requests, ideas, contest ideas. We'll be sure to keep the party rolling. So until then, guys, again, text me anytime you have any questions. We'll be posting this.
Of course.
Like, subscribe, ring that bell. Alex knows what I'm talking about. We appreciate you all. And until next time, have fun.
Make money.
And give impeccable.